If you are over 60 and you notice new forgetfulness, slower thinking, or brain fog, do not panic and do not self-stop your prescriptions, but do take one safe step. Look at your full medication list, including over-the-counter PM products, allergy pills, bladder pills, sleep pills, and anything for anxiety. First, an important distinction. Progressive dementia usually changes slowly over months to years. Delirium and medication-related cognitive side effects can appear faster, days to weeks, especially after a new drug, a higher dose, dehydration, infection, or adding multiple sedating medicines. Now, there's a real concept in geriatric medicine called anticholinergic burden. Some medicines block acetylcholine. In older adults, higher anticholinergic burden is associated with confusion, delirium, falls, and in observational studies, a higher incidence of dementia. Association is not the same as proof of causation, but the signal is strong enough that geriatric guidelines tell us to minimize the total burden when possible. Here are 9 categories to discuss in a structured medication review. Number 9. First-generation antihistamines used for sleep or allergies. Examples include diphenhydramine, doxylamine, and similar PM products. In older adults, these are strongly anticholinergic. They can worsen next-day attention, increase falls, and contribute to a high anticholinergic load. If sleep is the reason, the safer plan is not a sudden swap. It's a conversation about why you can't sleep and what approach fits your health conditions. Number 8. Long-term acid suppressors, especially when continued without a clear indication. Proton pump inhibitors can be very appropriate for specific diagnoses, but long-term use has been associated with lower vitamin B12 levels in some patients, and severe B12 deficiency can affect nerves and cognition. This does not mean PPIs cause Alzheimer's. Evidence linking PPIs to dementia is inconsistent. The responsible message is use the lowest effective dose for the right indication and review the ongoing need. Number 7. Bladder antimuscarinics for overactive bladder. Medicines like Oxybutynin have the best evidence for adverse cognitive effects among this class. For some patients, non-anticholinergic options may reduce anticholinergic load, but they have their own risks and must be chosen based on blood pressure, heart rhythm, kidney function, and other conditions.
Number 6. Benzodiazepines and Z-Drugs used for anxiety or sleep. Regardless of the dementia debate, in older adults, these drugs increase the risk of delirium, impaired balance, and fractures. If you have used them regularly, do not stop abruptly. A taper plan should be individualized and supervised. Number 5. Tricyclic antidepressants, sometimes used for pain, migraine prevention, or sleep. Amitriptyline is strongly anticholinergic and commonly causes constipation, dizziness, and cognitive slowing in older adults. Sometimes alternatives exist, but some alternatives can also increase sedation and falls. The goal is lower total harm, not new pill, same problem. Number 4. The SSRI Paroxetine. Paroxetine has stronger anticholinergic properties than most SSRIs. In older adults, it can contribute to sedation and cognitive side effects. If an antidepressant is needed, clinicians often choose options with lower anticholinergic burden. Number 3. Antipsychotics used for agitation or sleep in dementia care. These drugs carry an FDA-boxed warning for increased mortality in elderly patients with dementia-related psychosis. In some severe cases, short-term use may be considered, but only after assessing pain, infection, medication side effects, constipation, sleep deprivation, and environmental triggers, and with frequent reassessment. Number 2, stacking CNS active medicines. A common danger is not one drug, it is combinations. A nighttime antihistamine plus a benzodiazepine plus a pain medicine plus alcohol. The cumulative sedation and anticholinergic load can look like rapid decline, and it can dramatically raise fall risk. Number 1, polypharmacy without a medication review system. If you take 5 or more medicines, you deserve a structured review: indication, dose, duplication, interactions, kidney dosing, and total anticholinergic or CNS burden. Here is the SAFE plan. Step 1, the medication list audit. Write down everything: prescriptions, OTC pills, sleep aids, allergy pills, supplements, and alcohol frequency. Step 2, ask for a structured medication review with your clinician or pharmacist. A practical question is, which of these increase anticholinergic burden or sedation, and which can we reduce, substitute, or simplify safely? Step 3, if deprescribing is appropriate, taper with monitoring. There is no universal taper speed. The right plan depends on the drug, the dose, the duration, and your medical risks. If confusion is sudden or severe, or you have fainting, chest pain, new weakness or numbness, trouble speaking, severe shortness of breath, fever, or signs of dehydration, seek urgent medical evaluation. That can be delirium or a medical emergency, not just aging. Your brain is not doomed, but it is sensitive to medication burden as we age. Do not guess. Do not self-stop. Review your medicines safely with a professional and protect both memory and mobility.